With just a couple of minutes, we hope that we have your consent to record this session. Would love to hear from more of you. Just maybe drop a line in the chat of where you're joining us from. Wonderful to see. Thank you so much for sharing. Folks joining us from Assam, from Odisha, from Vadodara, from Sonipat, Nagpur, Mumbai, from Hyderabad as well, Chennai. Wonderful. Very warm welcome to all of you. I think if I have the green light from Kavita, then maybe we'll kick off. Wonderful. 6:05. Thank you all, folks, for being here. It is such a pleasure for the India Mental Health Alliance to host this session today for all of you. The India Mental Health Alliance was started in late 2023, early 24, really with the intention of building an ecosystem for mental health in India and recognizing that the only way to do that is to work with everyone and be able to co-create and build together. And with that intention, some of us who have all had a mix of lived experiences, some of us are clinicians, some of us are academicians, some of us are philanthropists, but really almost all of us have had lived experience within our own family that has sort of brought us to this space and in this context. I am Neha Kirpal. I'm the co-founder of the India Mental Health Alliance, also the co-founder of AMAHA, and here with you today with a very warm welcome. We have other colleagues from the IMHA team here, and I'll just take a minute maybe and share a little bit about what the aspirations have been for us as we set out on this journey. We've been doing several of these sessions on different topics. Lived experience has, of course, been a key thematic for us. Each time we've been joined by over 100 mental health professionals who have come, like yourselves, from different parts of the country. And these conversations teach us a lot. It's incredibly enriching to see the kind of dialogue and the way people want to come together. We see the need for a community and the idea of a collective emerging. Many of you have come back again and again from, I know we have a count of about 136 cities from where people have been joining us for different sessions. Last year, the last 2 years, we worked with over 1,600 psychologists. We are doing certain learning journeys now where we include multidisciplinary mental health professionals to come together, including lived experience experts. And so it's been an incredibly fulfilling journey so far. Early days, though. The alliance that we set out to build really has been a sort of a national association. Today, we have over 300 member organizations from across the country. And just wanted to give you a sense of how coming together, sharing knowledge, connecting with each other, co-creating, builds for collaborations, builds for deeper connections where each alliance member organization and their representatives can really sort of benefit over time. And so this is sort of a broad representation just to share with you from across the country how the membership base of the India Mental Health Alliance stands today. And within this, we have mental health organizations, we have caregiver collectives and lived experience experts collectives, as well as cross-sectoral organizations. So a lot of the work has really been to look at mental health as a developmental issue and bringing cross-sectoral organizations from education, livelihood, women and child together with mental health to be able to really build an ecosystem of care and support. And we've also sort of made the early steps to set up a knowledge hub that hopefully is a live, ongoing co-created space with a knowledge repository, a video repository, but also ongoing exchange between member organizations. So the hope really is each of these sessions builds a collective for us, and we are able to create more immersive sessions, learning from each that we have done, and from all of you. So thank you so much for coming. Without delay any further, I'm going to hand over to Dr. Kavita Arora. Kavita is a leading child and adolescent psychiatrist, been practicing in India for, I think, 25 years plus, gender-affirmative care practitioner. Kavita is the co-founder of Children First, which is a child and adolescent mental health organization based in New Delhi and Gurgaon, and is also the founding cohort member of the India Mental Health Alliance. So Kavita, over to you to kick off the session for today and also introduce the rest of the panel and our guests. Thank you all for being here.
Thank you, Neha, and thank you to everybody who's here, but especially our speakers today. I'm going to take a minute to actually bring them on and then set context. 2-3 things in terms of hygiene points for the audience. We will take questions towards the end. Please feel free to put questions in the chat. During the time that the three of us are dialoguing, our request is please keep your mics off. We will give adequate time for questions towards the end. Please do keep an eye on the chat box. There will be resources, there will be other things that you can actually download or look at in the chat box. We welcome more questions. We had sent across an RSVP form which had questions about what you might want from a session like this. I'm going to talk about the context a little bit as soon as I'm able to bring on KP as well as Jenna. So I'm going to try, if somebody could help me with the slides, I'm going to bring KP on first, or Jenna on first. There we go. Sorry about that. I think we could bring them both on, and then I can introduce each one of you. It is my absolute pleasure and privilege to introduce today Jenna. Jenna is from Cape Town, from South Africa. They are a clinical psychologist, but a lived experience ambassador and advocate. They are a researcher. They are the co-author of key resources on gender-affirming care, whether it is for South Africa or it is for the Global South. And they are also co-chair of the Diversification Committee at the WPATH. So in many ways, they're working at many different intersections. Mental health, gender diversity, disability justice, global impact, all of it together. And they have done this absolutely fantastic PhD that we are going to hear a little bit about right now. They've agreed to help us and exchange knowledge and information that they've gained with this study. I'm really thankful, Jenna, and it's been a pleasure in the last few weeks to come to know about your work and about you. Thank you for joining us from Cape Town.
Thank you.
Yeah. KP. I don't know how many people don't know KP in India, but KP is assistant professor faculty at TIS, Mumbai. They are a lived experience advocate as well, a leading voice and author in the queer affirmative mental health policy making, in practice, in training, in research, and I've had the pleasure of now being on panels or in discussions, and hopefully now we call each other friends as well. So welcome, KP. I couldn't have thought of a better person to have this dialogue with in India in the current context today. So welcome.
Thank you. Thank you. Happy to be here.
Yeah. So I'm going to talk a little bit about how we're going to conduct the session today in terms of the flow. When we started off with this idea, it was more to do with the impact of the amendment that came out in March 2026 and some of the confusion that was happening thereafter. However, as we put this together and sent off feelers and asked for RSVPs, a lot of you who are present today have responded with saying, we want to know about gender affirmative care in its entirety before we start talking about the amendment. Very few people talked only about the impact of what the amendment is. So the way that we are now going to talk in the session is first talk a little bit about gender affirmative care, what it might mean globally, but also in the Indian context right now. Then anchor ourselves in an actual case vignette or a story. Oh, Jenna, that's lovely. Oh. We've got company. Lovely. So then we will start with we will go into a story of the Indian context, and we will then comment on it. Jenna will introduce us to the framework that they have studied and come up with, which will help explain and anchor us in how to reflect on what's happening during times of stress and uncertainty, where healthcare providers are wanting to do ethical practice, and yet there are questions around it. And thereafter, we will move into talking about the amendment and its impact. So I'm going to start off by a very simple, basic question that I think people are afraid to ask because it sounds silly or simple, but I think it seems like it's the most important question. And that is to say, what is gender affirming care? What does it really mean in terms of the concept, in terms of the word gender affirming, and in terms of the word care? So Jenna, would you like to kick us off with your version of how to explain this?
Sure. Yeah. Well, yeah, I think gender affirming care, I think, is often misunderstood as being like just about sort of medical transition and things like that. And I think that it's often oversimplified. When it's almost as though you can imagine as being like a suite of different kind of aspects of care. And it can be the sort of medical related ones. So if it is around hormones and surgeries or puberty blockers, but then there's a whole range of non-medical interventions, from supporting with social transitioning. So that can include like name changes and pronoun changes, appearance, dress. Voice work is one of those. Also referred to as like binding and tucking, which is also, it's around sort of appearance, but it can be incredibly affirming for a trans person, which just sort of aligns more with their identity and who they are. And yeah, I think gender affirming care as such is it's a process of actually supporting people in exploring their gender identity and experience. So I think there's sometimes a misconception around what the word affirming means, whereas actually it's not about pushing somebody towards a predetermined outcome. It's actually staying with the person where they're at. It's person-led, and it's around what their expectations are, what their needs are. I often start like the first sort of intake session with telling the client that I am here to deliver a service and I want to know what their expectations are and if I can actually help them with that and meet those expectations. So it isn't, I think, again, there's a sort of a preconception that a lot of it is around assessment. and that it's around assessing identity when in fact it isn't. And I think we'll, explore and discuss that in more detail as we go along. But it really is about supporting people. I think the other key thing with affirming, and just affirming practice in general, is that there's I can say, like, there's almost like there's a political angle to it. That you need to have an awareness of what the socio-political sort of conditions are that actually act upon the care structure itself, but also on your clients' lives, and what they're dealing with. And so within a therapeutic setting, part of what you do is you actively try and counters may be too strong of a word, but sometimes it can actually be a little bit more like that. But where there's a real effort to try and acknowledge and unpack what some of those pressures are that act on people because of socio-political, historical, and other contextual issues.
Wonderful. Thank you. Thank you. So a space to explore, not necessarily affirming doesn't mean just agree. It is to provide that space to explore by listening, by being present, by bringing in everything else that the person may be bringing in, and being aware that they are bringing in a lot of different contexts, but preserving their sense of agency and their sense of who they are, within their context. Wonderful. Can I move to KP and request them to bring in a little bit more about the Indian context of a person walking in?
Yes, thank you. And before I speak specifically the Indian context, just starting from a more universal in some ways, what Jenna referred to as political movement, social political movement, when we are talking about gender affirmation. So for me, when I think about, so there's gender affirmation and there is, of course, gender affirmative care. But first, when I talk about gender affirmation, when I think about that, what comes to mind is anybody who is able to understand that all of us at birth are given an identity, which is that of the sex that you are assigned.
Yeah,
And
yeah.
the first identity, sorry, is that okay? Yeah. So the very first identity that all of us are given at birth is sex. There's an assumption that this sex leads to gender, and in some ways, an assumption that this gender leads to asexuality. So the idea that there are all human beings can be divided, all human bodies and babies can be divided into two types of bodies and two types of sexed bodies. And from there come two types of genders. And the idea that eventually, as these two genders grow up, they develop attraction to each other and therefore one kind of sexuality. So my sense is that anybody who is able to disrupt this is being affirmative. Anybody who's able to say that for me, sex is not equal to gender. And so if I say, for example, call me KP and not by my birth name, and you just call me KP without any follow-up questions, that means you're being affirmative, right? Because you're saying that a lot of stuff that is naturalized, that this was a name, so this was a sex given to you at birth, this was a gender given to you at birth, this was the name given to you at birth, this is the religion given to you at birth, this is the caste given to you at birth, and so on and so forth. Anybody who's saying that, and it's not, I mean, I understand that to be able to break away from any of this is not easy, but I'm just saying that anybody who is able to disrupt this idea that, first of all, there are only two kinds of bodies, two kinds of sexes, two kinds of genders, one kind of sexuality, but also the idea that there could be this sex given to me at birth, but this is not my gender. So there are some of us who, as we grow up, we get along with the body and the sex that was given to us at birth, and we are cisgender people. And then there are those of us who don't get along with the body and sex that was given to us at birth, and we are transgender people. So I think that for me is the broad idea of gender affirmation. And anybody who then from here does not go into saying, oh, so if you're a transgender person, I must look for a cause. So if a boy is behaving like a girl, why is that happening? Yeah, no, that's not gender affirmation. The fact that I feel like I want to ask these questions, that is anti-gender affirmation. Or, why change something that was given to you naturally? This body was given to you, this name was given to you, and so on. Why are you wanting to change any of that? Anybody who's doing that is doing anti-gender affirmation, right? Or the idea that you will grow out of it. you're a kid now, you don't know, and we have, I mean, we have so many, like in media, so many of these symbols and images of those of us who would know Bollywood, we would know of this idea of as the tomboy girl meets the right kind of guy, suddenly the gender is all in place and sexuality is all in place and all of that, right? And we've seen so many of these kinds of movies. So I think, yeah, so just to say that gender affirmation is self-determined gender, not connected to body, not connected to naturalization, normalization, etc. And saying that this is your gender, I accept this without any reservations and doubts. So that's for me gender affirmation. But what is gender affirmative care? And I just want to bring people's attention to one of the resources that has been shared, which is called Indian Standards of Care. And Dr. Kavita has authored this wonderful chapter on mental health of trans people there, which starts out actually by saying gender affirmative care. So if I am a teacher, for example, what would this care look like? What if I was a principal? What would this care look like? If I was a parent, what would gender affirmative care look like? So similarly, if I was a mental health professional, as a mental health professional educator, what would gender affirmative care look like? And like Jenna said, that often it gets restricted to the idea of providing assessment for people who, so in some ways we are providing the first service as mental health professionals, and therefore sometimes also we are called the gatekeepers, right? Because we are the first guys who then will do some stuff which will decide whether the person is able to access other kinds of gender affirmative interventions. But I also want to, because we will talk more about this later, so I'm not going to go into too much of that on assessment. But two other things for which I feel trans people come to mental health professionals. One is that we know now, research globally and also Indian context tells us that trans folks will have more prevalence of certain kinds of mental health problems. So particularly common mental health issues, so depression, anxiety, substance use, and suicidality is likely to be disproportionately higher among trans and gender diverse people. Now, gender affirmation for me would be understanding that this prevalence is higher because of what is called as gender minority stress, and not because something is terribly wrong, inherently wrong with trans people, which makes them more depressed and so on and so forth. So that's one of the things to think about as a mental health professional. Gender affirmative care would be about understanding that trans people will need more mental health support, should actually get more mental health support. Whether they get it or not is a different story. But therefore, how is it that I'm going to support people who have more distress compared to maybe my cisgender clients? And the third one, which I think is particular and specific for the Indian context, is trans people and their family members and other people in their lives will bring these folks to you for conversion treatments. And that's the third context in which, so mental health professionals will engage with trans people, one in the context of assessment of gender dysphoria, second in the context of dealing with mental health problems, and third in the context of conversion treatments. And I think gender affirmative care dimensions will have to be thought about at each of these. The third one, we do have, I think, both professionally, many, so almost all associations of mental health professionals in the country have said conversion treatments are to be banned, are not to be supported, they are not evidence-based, they cause a lot of harm, and so on and so forth. We also now have court judgments that tell us that conversion treatments are not okay. So obviously, gender affirmative care in that context would mean not engaging in conversion treatments, but also advocacy efforts to stop them. So that's just my initial opening bits about what would gender affirmative care seem like. Thank you.
Yeah, thank you for that. I think that builds the context that why do we need more? Why do we need to think about this more? I think that's one of the questions that I've always wanted people to think about as healthcare providers, that there are certain sections of people who approach us who come with a story and a history of discrimination by power and systems that have either invisibilized them or have not taken into account or centered care around them. And I think trans folk are one such. And unless the healthcare provider is aware of this part, that what is being brought into the room is from my side as a healthcare provider, maybe my unawareness, because it is not part of my curriculum or not, or has not been, and B, the discrimination history and possible minority stress and trauma that the person entering the room on the other side is facing, that you're not really meeting on the same footing. And to be aware of this is also part of gender affirmative care and needs to be part of gender affirmative care. Yeah. Okay, so I'm going to ask a very practical question for especially the young practitioners who are on this call, who have asked, so this may be okay in ideology. What does it look like? What does my waiting room need to look like? What does my intake form need to look like? What does my vocabulary need to be? What are the actual ways in my practical, ordinary, everyday practice that actually can help me be gender affirmative? Open to either one of you or both. Would love for comments on that. I think some of the things KP has
Yeah.
started off with, but
Mm. Yeah, I think that when like trans and gender diverse clients like initially come to you is because of past experiences and often with other healthcare providers, they can come in like being quite distrustful. And so it's almost as though like, and it's to protect themselves, you know, it's not like, you know, because they innately don't trust you. And so there's almost as though they're constantly assessing whether this is a safe space, whether this is a space where they are going to be like seen and accepted. And so healthcare providers can do, you know, little things that almost as though they're indicators or signifiers that you are affirmative. And one of the easiest ways actually to do it is from the beginning with your intake form. So your intake form, if it's inclusive, if it includes things like what your pronouns are, you know, if it differentiates between what the legal name is, maybe for, you know, medical insurance purposes or that kind of stuff, versus what's the name you actually go by. And yeah, and I think that's in some of the resources that I've shared, which I think will be available. There are examples of intake forms that are inclusive at the end, which you know can easily be, I think, modified to different contexts. In a lot of the work and research that I've been doing specifically around conversion practices in Africa, this also becomes like quite a tricky thing because in so many countries in our continent, like sexual and gender diversity is illegal. And providing like care is, you know, is actually can also be considered illegal. And so if there are like little visual things like say now you have the inclusive pride flag or the trans flag or you know something like that in your room or you know that acts as like a signifier, you also have to be quite careful about it because you could be raising suspicion or you know like to the authorities that might be you know seeing you or like kind of scrutinizing the care that you're wanting to provide, and that can also deter people who maybe don't feel comfortable with it being like being out or you know people being aware of it. So I kind of say that if you do want to use like things like that, rather do it inside the room and not outside, you know, just to sort of protect people and their privacy. And then the other big thing is around language. And there definitely are, you know, ways in which you can sort of the terms and things that you use that can be more sensitive. But with so many of the people who I've talked to, what the majority of like trans clients have said is that yes, there are certain terms that are like can be quite offensive. Um, but it's usually what the intention is from the provider behind it, as opposed to what terms they're actually using. So I think it's even more pronounced in the Indian context, but in South Africa we have 12 official languages, and I often think about that in sort of multi-plural kind of settings, is that language, it changes. So in quite a few of our languages, pronouns don't exist. specific terms for trans people and gender diversity, they differ. So I think because of that, there is at least in my experience, that there is a high tolerance of language use and terms that you use. But it's usually how you're using those terms, and what the intention is, that I think can have quite an impact on whether the person trusts you.
Absolutely. So I think the building of trust is not necessarily only on the basis of language, but
Yeah.
the intention of even finding the right language and being able
Yes.
to be respectful with the use of language and provide choice and agency about the use of pronouns and language. I think if someone is trying that, I think as human beings, all of us can figure out the vibe. We have
Yeah.
those receptors inside us. We're usually
Yeah.
able to figure out this person's actually intending to be respectful and intending
Yes.
to be inclusive. And I think that is something that we can all hold on to.
And
Um,
I think one of the best things is actually just to ask. It's just to ask the person what language, what terms they prefer, and also asking what terms is okay for you to use. Because if you're a cisgender person, there are certain terms that maybe aren't appropriate for you to use, but that trans and gender diverse people can use. So it's like how the trans person maybe refers to themselves is not necessarily how they want their healthcare provider to refer to them.
hmm.
Um,
Could you
yeah.
give us an example of that, Jenna? I mean, is there something that came to
Um,
mind? Hmm.
well, I think it's quite, I mean, I find it quite interesting in like again, in the South African context, how there historically have been terms that have been used to sort of insult queer people,
Hmm.
and that have been derogatory, but how the queer community have actually taken some of those terms back. And I
Hmm.
think queer is like a perfect example of that globally.
Hmm.
But there are also specific terms in the South African context. And so a trans person might refer to themselves in that way.
Hmm.
So, I mean, a specific example is the term morphe, which
Hmm.
is like a very derogatory term generally for a gay man who's particularly feminine.
Right.
And yet it's also a term that a lot of trans women actually use to describe themselves,
Yeah.
particularly those who are in relationships with men.
Right.
So they might refer to themselves as a morphe, but they're definitely not going to want their doctor to call them that.
Right. Well, there you go. So choice, asking, being open to asking what the other person wants. Beautiful. KB, any comments on that before we move to, yeah?
Yeah, I was just thinking about language. It's what Jenna was saying. I was also thinking of one of the things about I mean this thing about, of course, pronouns and names, and which is stuff that we are saying in the context of specific reference to trans clients. But also, I wonder whether you know intentionally using language for the normative is also an important part of being trans affirmative. And I find, for example, the study that I did some time back with mental health professionals, and we had questions, obviously, demographic stuff, right? So we have a question on gender identity, right? And a lot of cis mental health professionals would actually say something like, what does this question mean? Or, I mean, like, basically, can't you see who I am? Right? I don't feel the need ever to identify as anything, right? So, I mean, I've actually had responses like, I'm a man, right? I mean, not a cis man, right? I'm a man, right? We just say like, I mean, this is, so I think it's interesting that, so language, which is also, so what that means, the man means, can't you see? This is natural, this is the normal, the right, the correct normative way to be. So I think that in some ways about affirmative language is also to use the term cisgender, like we use the word transgender, right? So I think that's important as well. I mean, I think there are a lot of people, and particularly for mental health professionals, I think if we learn to say heterosexual as opposed to saying, I am a regular guy, or
Hmm.
I'm a man. Yeah, to say I'm a cis man, I'm a heterosexual man, I'm so on and so forth. I think it's like we qualify that which we consider to be not normative, and that which is considered concerned that this is the way to be, we don't feel the need to qualify that. So I think that's just something on affirmative language that I wanted to add. The other thing I wanted to say, which I learned much later, not from textbooks actually, that a lot of people who post transition may not want to refer to themselves as a trans man or a trans woman, particularly binary trans folks. So people may choose to say that I am a woman of a trans experience or I'm a man of trans experience. And I think those are things, again, to be sort of what Jenna was saying earlier, just to be more mindful of what I think it's a very, very specific meaning when someone says that I'm a woman of trans experience, as opposed to it's not the same as trans woman. So it's just to pay attention to gender journeys, affirmations, self-affirmation, self-identification of people. So I think just calling attention to that again. Yeah, thanks.
So I'm going to summarize that by saying that it is not a script that anybody needs to learn. It is actually a position and a stance of respect. So just for the audience, you don't need to learn all of this, because sometimes it becomes overwhelming to say, now, do I have to learn another name, another kind of subset, etc., etc. You don't. It's not a script, but it is definitely a position that you're taking, a position of curiosity, of giving the other person respect and agency, and asking them how best to address them and how best not to address them. So not assuming that you know better and that mankind has known better. I've deliberately used mankind there, has known better. So just to point out, there are simple things, but the Constitution of India, for example, starts off with the phrase, "we the people."
Yeah.
It does not say ladies and gentlemen. So just to say there are many different ways in simplicity about being inclusive, respectful, and informed. I'm also wondering, we were talking a little bit about what does a mental health provider assess, or what is assessment look like when somebody comes to us? What do we and I think it's time to actually maybe anchor ourselves in an actual scenario. So I'm going to bring a story in, the story of Arav. Thank you, Anandita. So for the benefit of the audience, this is not a true in the sense of, this is not a real person. This is a story that one has sort of constructed out of the experience. So Arav is a 24-year-old a man from a semi-urban town in Maharashtra. They've just moved to Bangalore, and they have approached a psychiatrist in Bangalore. They socially identify as a male for the last 4 or 5 years with their close friends. After relocating to Bangalore, they're seeking a referral for hormone therapy from a psychiatrist. The psychiatrist themselves identifies as someone who practices gender-affirming care, and they have reportedly used informed consent approaches in the past. Arav says that earlier in their hometown, they have actually seen a psychologist for about 6 to 8 sessions, and those letters are with them. So when they come to the psychiatrist during the assessment, the psychiatrist asks specifically about childhood gender stereotypes. What did you wear? What kind of play did you have? What was your appearance like? What was your dating history, social media presence? And they insist that they have to have a real life role and prolonged social transition before undergoing hormone treatment. And Arav presents the therapist letter in response to this from Maharashtra, documenting how they have actually been through several months of therapy. The letter says there is absence of psychosis. There has been an assessment done to actually do projective testing through Rorschach and personality testing with an attempt to do personality tests. And all the reports are there. Arav presents this to the psychiatrist. But the psychiatrists feel this is not enough or sufficient evidence and ask Arav to meet a therapist in Bangalore that they are aware of for at least 7 to 10 sessions. And Arav, over a period of time, tries to do that, but then eventually disengages from their care journey and drops out from this psychiatrist. So this is fairly commonplace in many of our big towns. I would have seen many Arabs in the last 20, 25 years. I'm going to request KP to talk a little bit about what they see in this context of the contact with the healthcare professional, the experience of this contact with the healthcare professional. What do we think was actually being assessed? What was happening here? And maybe point us towards a little bit towards what could be done differently, but we'll come to that later.
So I think, as you said, Kavita, this is unfortunately a very common scenario that we come across. You've seen that in your clinics. I've seen that in a sort of study that I've done and folks that one meets in the community. So what's happening actually, if one were to break this down, one I think thing that's happening is that I think for particularly cisgender socialized mental health professionals. And here I'm saying cisgender socialized because I'm saying social learning is that of what I said earlier. There's a naturalized idea of two bodies, two sexes, two genders.
Yeah.
So if there is something that is not normative around gender that I come across, my mind immediately goes to what's wrong here. And if I'm trained as a mental health professional who is trained also to look for psychopathology, diagnosis, etc., then my mind goes to, is there a delusion here? Is there a personality issue here? What else? Like, what is clinically going on? So what that does is that my usual practice and training and my stance of curiosity and, sort of genuine curiosity, authenticity, trust with my clients, which might be when I'm listening to, say, somebody's story of depression or, somebody having a bad time with their mother or, something like that, or, a young person having trouble with their parents, etc. I'm generally somebody who's very curious about these things and I want to understand where the person is coming from. But when it comes to when there is some deviation that happens, particularly around sex, gender, sexuality, my mind goes to somewhere else. And I'm wanting to understand that is this secondary to psychopathology? Is it secondary to trauma? Is it secondary to something? Because I'm not, in my mind, I don't think of this as okay. Like this, people can be like this. There's diversity. Like I would say that, a young kid, 18, whatever, 20-year-old hates their parents. I mean, that's just how it is, right? I mean, and you just take it and you go with it and you run with it and you work with it, right? So you don't think of this as, oh my God, this sounds delusional. That's not you. So I'm just saying that this is there. So there's something like that happens with cisgender socialized mental health professionals. The unfortunate thing is this socialization is not getting sort of channelized or trained in a mainstream curriculum. So the curriculum is not teaching me about, so for example, if the curriculum were to teach me that the ICD-11 talks about gender incongruence, which is no longer a type of mental disorder. Gender incongruence has moved out of list of mental and behavioral disorders and has moved into a chapter called sexual health. Or if I were to be trained on these things, then naturally what will happen is that this cisgender wiring in that sense will already be sort of saying, okay, so what is the protocol for gender incongruence? What do I have to look for? What I have to look for is basically, is there gender incongruence? I'm not really here to assess anybody's identity. I just want to know, is there gender incongruence? What is the distress that's causing? And is there any other psychopathology that I also need to keep in mind when I'm planning my care plan? That is what normatively should happen if I was well trained, but that's not what happens. And so then what ends up happening is some of these things that what we see with this psychiatrist is that they are going into, one is that they're going into stereotypes of gender. So they're saying that if you are today a real, true, authentic trans person, then you must have had these experiences of being gender incongruent from the time you were born. So now I want to know that whole history and I want to see that this authentic transness has been present consistently in a linear way for all these years. And then I want to now also look at projective tests and personality tests and all of these kinds of things. And so what is ending up actually happening, and I'm just going to quickly in a minute show you two slides to show you. These are both examples of two studies that have been done in India. Just a minute.
So while KP gets their slides, I think the ICD-11 stance of gender incongruence is something that all of us as healthcare providers should be well versed with. And ICD-11, the difference from ICD-10 was the depathologization of the gender identity itself. So only when there is incongruence, distress, then we are looking at assessment. So back to you, KP.
Yeah, so this is just to point to a study that was done with trans-mask folks in India. About, I think, over 300 people participated in this study. And one part of the study is presented here in this particular paper. It's available online. People can look up. I'm going to just draw your attention to two things in this. Sorry. You can still see my screen, right? Yeah, okay, perfect. So one thing is these participants are talking about the mental health experiences with mental health professionals, and they're using the language of they're saying, I got my approval for transition, right? And then they're talking about something called as passing the assessment. Okay, so that tells us something about what is this. That's exactly what is going on with Arav in some ways, right? Because Arav is being put up in this situation by the psychiatrist, who's basically sort of making him jump these hoops and prove himself. So this just the idea of approval and passing, and I think what is even more, so that's something about expert power, knowledge, all of that. But I think even more dangerous is this quote that is used in this particular article, where this trans man says that my friends told me to be cautious in discussing my mental health problems with who? With my mental health professional. I should be cautious in talking about my mental health challenges to my mental health professional. Why? They said, my friends told me that whatever the doctor asks, speak positively. If you feel disturbed or negative or uncomfortable, the doctor will cancel your GID. GID refers to gender identity disorder, which is the language of the DSM-4 earlier. So I answered positively, gave the test. After the test, they gave me a GID. In one day, I got 2 GIDs because I had to do a small surgery. 1 or 2 GIDs compulsory. So I took 2. Okay. Now, what is this compulsory? What are these standards? What are these protocols? What is being followed? I mean, I think it's just what we see, what is there in the Arav case just reminds me of, the kinds of things as a 26-year-old person, like Arav, 24 years old, has lived with gender incongruence, dysphoria for a while, possibly for a long period of time, is looking for care, and these are the kinds of hoops that they have to go through. The other thing I wanted to show you, this is a study that I did with 165 mental health professionals in 3 cities of Bombay, Delhi, Bangalore. I call my paper In Quest of an Authentic Identity. Yeah. Sorry, I'm just having a little bit of trouble with.
No issues. We can see your.
Okay, you're able to see, right? Okay, so what I see, what is in this particular study that we did, mental health professionals told us about the kinds of assessment protocols that they follow, and I mean, I really do. I mean, I don't know what is so many people following this thing of using projective tests, using personality tests, using IQ tests, and these are all adult trans folks who they are seeing in their clinics to assess, purportedly to assess, whether the person has gender incongruence, and just to be able to give them a letter of support. Again, the idea of using certificate to refer to somebody's gender. So those are some of the things that we point out in this particular article. I'm just going to stop sharing. Has it stopped sharing?
Yes. Yes.
Yeah, okay, thanks. So, so you might want to look at this article, and I just want to point to again some of the material that I came across while I was working on this article, is that increasing. I mean, this whole thing of mental health professionals playing this gatekeeping role. It almost sounds like we are on some kind of an excavation. It's actually there is somebody who's written an article called "A Rose is a Rose," and he actually says that this is like an excavation project. That we are. What are we trying to? What realities are we hoping to uncover? And we see something very similar happening with the amendment to the Trans Act that's happened in India right now, but that we'll go into a little later. Um, I also want to point out again in this article about looking for the authentic trans person, we also heard narratives from mental health professionals, which were actually saying that they feel quite, that they can see that their clients don't trust them, trans clients. Folks are saying that, sometimes I wonder that it's only because it's compulsory that people come to me. Otherwise, they would not come to me. And when I try and point out that there are some mental health challenges, people are really resistant. They just get angry and they think that we are somehow stopping their journey of, So this person is actually feeling, is sort of feeling bad that they are not able to reach out and not able to support, not able to do much because of this sort of gatekeeping overall that happens from the mental health professional community. So yeah, so that's just a few thoughts on the Arav case.
No,
Yeah.
thank you so much for that. And I think that is that is common. That is quite common right now. And mental health professionals sometimes are unable to see. We are unable to see our own implicit bias, but we are also unable to see what this kind of stance actually changes, because the trust is lost. And this is no longer a therapeutic stance. You cannot hold a therapeutic stance when you are supposed to provide approval. It just shifts. The power hierarchy has shifted, and this is not a trustworthy relationship at all. So I think that's something that we all need to, I think, hold with a lot of humility and a lot of awareness. I'm going to now request Jenna to tell us a little bit. Um, I know that there have been different but similar contexts in South Africa, where which has prompted you to study how healthcare providers can continue to be confident and continue to actually practice, and what are the things that we may need to reflect on as we live in these times, which are very real, and yet continue to provide ethical services and gender affirmative care. So I'm going to hand over to you for you to talk about Arav, but from the point of view of the study that you have done. And to the audience, I found that this was an absolutely fantastic framework. I would urge you to put everything else aside and concentrate for the next 10 minutes on the work that Jenna is doing. We will be sending out the resource link. So some of this work, Jenna is very kindly, they've not yet published it, but they've kindly done a summary document, which is in the resource list that you will be able to access. Alongside that, some thoughts from the three of us on Arab story in a wider document are also there. So the only reason I'm telling you that as audiences, please put everything else aside and try and listen to what Jenna is going to now talk about for the next few minutes. Thank you, and over to you, Jenna.
Yeah, thanks, Kavita. So this is a lever model that I've developed through my PhD research over the past, I think it's taken me 9 years. But it's essentially a model that looks at trying to understand how it is that healthcare providers and trans people have continued to engage in gender affirming care, despite all of the sort of political, like contestation around gender affirming care and around trans people. So I've called it Staying in the Work. And just a bit of background. So I don't want to go into too much detail into the academic stuff and rather just get to so this is very brief. But it was a classic grounded theory study, which is essentially about finding a theory to explain a basic social process that is grounded in the data. So I interviewed trans participants, I interviewed healthcare providers, and then I also looked at a corpus of anti-trans discourse. So in other words, like the sort of anti-trans groups and people that have published things in the media and in journal articles and opinion pieces. And what through grounded theory, what you ask is the people who you interview is that what is their main concern? So what is their main concern around gender affirming care? What conditions are they trying to deliver care in or access care in? What are the strategies that they use to try and resolve those concerns within those conditions, which tend to lead to consequences, and those consequences can become new conditions. So the research is based in the South African context, and we have a couple of things that I think just is unique to like our constitution, for example, and our human rights framework is it's very progressive, and a lot of our healthcare and education and everything is based on that constitution. Obviously, the reality, like the laws are incredible, but the enactment of those laws, that takes time. But yeah, South Africa's healthcare system is very uneven. So the majority of our population accesses care through the public healthcare system, which is generally under-resourced. It's uneven in terms of rural versus urban. And there tends to be long waiting lists. The gender affirming care, the transgender unit at one of the big hospitals here in Cape Town has a waiting list of over 20 years for surgery. Yeah, so it is quite hectic. And then our private system is a far smaller percentage of the population that can access private health care, and that's usually, through, funded by like their medical aids and things like that, which can be quite expensive. But essentially, the backbone of that private healthcare system are your GPs. So your general practitioners are most often going to be the first person a trans person actually sees. And within our guidelines, so South Africa has its own guidelines, that's based on WPATH standards of care, but adapted to our context, bringing in our human rights more, and just the reality of our context. And so according to our guidelines, if you're an adult, the GP can make that decision with you about whether or not, for example, if you want to start hormones, you don't actually have to have a mental health care assessment at all if you're an adult. If GPs are worried about your mental health, like mental health assessments, when it gets a bit more complex, is out of their scope of practice. So they often will refer. Quite often they refer not necessarily because they want the person to be assessed further, but because they want them to be supported through this process. It is a little bit different with youth, and I know that there's quite a few questions that I've already seen that's come up around youth. So those are in tabs in the back of my head, and I'll get back to them as we go along. But it's been in the past, say 10, 20 years, there's been a lot of progress that has been made in South Africa. So the PATSA, the Professional Association for Transgender Health South Africa, that was formed in 2020. As I mentioned, we have our own guidelines. Training opportunities have increased. I mean, I didn't get any formal training on gender affirming care. I think in my master's year, I think the least that we got was probably how to diagnose gender dysphoria, and that was maybe one class, if that, and it was very pathologizing. Some of the doctors that I interviewed, the one actually said they're so grateful that they have such a bad memory so that they can't remember all the rubbish that they were taught during their tertiary education. And then the other thing, which I think is an incredible victory and also a strategic point in terms of the sort of public and broader policy environment, is our National Essential Medicine List, the EML. So it took years, many, many years. My colleagues struggled, worked very, very hard. But estrogen and testosterone are now listed as treatments for gender dysphoria. And that's just given it a lot of credibility. We still need to work on it a little bit, because how it is structured at the moment is that it can only be provided at the tertiary healthcare system, which means that trans people have to go to like tertiary specialist hospitals. And so what we're working on now is getting it into the primary healthcare system, and so that people can actually access it through their local clinics. We did have several clinics across the country that provided gender affirming care within a broader sort of sexual and reproductive and HIV/AIDS context through our key populations programs. But with the USAID funding cuts, those clinics have all been closed down last year, and so hundreds of people lost access to hormones and to just comprehensive care. Through the clinics, they were able to see social workers, psychologists, the nurses, the doctors. They were very strong, like peer support groups, and that, yeah. So there's currently a big national sort of assessment that that's unfolding because they're trying to figure out where have people gone to get care. What we do know is that most people are not getting care. Some are getting it through informal sort of systems, which, does carry its own risks. The majority cannot afford private healthcare. And then it just ends up being that the waiting lists for some of the clinics that are still around have just grown. But in any case, we were making progress. And then at the end of 2023, the first anti-trans group, First Do No Harm Southern Africa is what they call themselves, associated, and they started publishing anti-trans and anti-gender affirming care stuff in the media and in journal articles, and that caused a bit of a panic. What they were doing is they were framing gender affirming care as being unsafe or unethical. They talk a lot about the evidence base not being adequate. One of the big things they tend to talk about is in terms of the lack of evidence, is also just a lack of like the nuanced understanding of pediatric healthcare as it is, because they tend to go after youth care because of the considered vulnerable population who are subject to adults who are full of all sorts of gender ideologies that are persuading people. So it's their, I think, strategy to kind of target youth. But in pediatric medicine, you don't have big like RCTs, there aren't big studies that have been done, for ethical reasons. But it doesn't mean that there isn't evidence at all. So what they also then ended up doing is actually targeting some of our healthcare providers, and they've reported a lot of healthcare providers to various ethical bodies. They have taken a couple to court.
Wow.
And it's made providers very, very anxious and not wanting to provide care, or they may be not taking new clients on. They're not advertising their services anymore, and it's caused a major disruption in the past 2 years. So what I then looked at with my research is trying to understand all these different dynamics. And essentially, this is about power. It's about, who gets to decide if something is evidence-based, who gets to act on what to do with that evidence. And so the lever model looks at 4 different aspects of care. And it doesn't like replace the guidelines. It's not actually about what to do in gender affirming care. It's about how to diagnose the sort of the system and the structure around gender affirming care. So the first one is around authority, so decision making, and this is within the particular context. It's around who has the recognized authority to be able to make decisions. Ideally, that is within the doctor-patient relationship or the therapeutic relationship, and that is what gives care the relational legitimacy. And what's necessary is for institutions and for broader services to recognize that authority that the doctor patient have. And under pressure, what happens is that authority tends to get taken out of the therapeutic relationship, and it goes to review committees and, you know, the external reviewers, administrators, and a lot of those processes tend to be very vague, which just complicates it even more. Then the second thing is looking at proof. So there's proof around the actual evidence, that's part of it. But otherwise, within gender affirming care and making those decisions, is what is the information that's needed in order to decide what the next step should be. And within gender affirming care, it's all should be within the informed consent model. And so what you're actually looking at is not, is this person trans enough? Or it's not a test of their identity, but it's looking at their capacity to consent, their understanding of what their treatment options are. If they don't get the treatment, what that would mean. If they did, you know, what that would mean, and how they they reason through this. It is also, it needs to be developmentally appropriate because there are different considerations that you're going to have for youth as opposed to with adults. And I know South Africa's legal system is, I think, quite different to how I understand the one in India. But for us, age of consent without parental assent for medical treatment is age 12. The law is very specific, though, in terms of it's not just chronological age, maturity is also considered. But what it means is that the law recognizes your capacity if you're 12 years and older. And so you as the patient or the client, it's not your responsibility to prove that you have capacity because it's already determined that you do. So if the provider is in doubt, it's the provider's responsibility to prove that this person doesn't have capacity.
That is really progressive. I think in India, especially, I am finding it difficult to imagine assent and this kind of sort of agency provided to 12-year-olds plus. It is very difficult. I'm also wondering, Jenna, in the interest of time, whether we could bring Arav in within the levers and explain how that might fit for the benefit of the
Sure. And that just, I mean, just to say on that is that it doesn't happen in practice where a 12-year-old comes in and just gets care. You know, care is expensive. You know, families and parents and carers are inevitably involved, and our guidelines strongly encourage a multidisciplinary process and parental involvement. So even though the law kind of gives us that sort of space within our guidelines, it you know, that's not actually how it works in reality.
Sure.
I'm gonna then skip ahead, and I'll still be able to talk about what the different levers are, but looking at Arav's story.
Yeah. Can I interrupt for 30 seconds and ask everybody, because we've reached the 1 hour mark. Is everybody okay for us to talk for at least another 7 to 10 minutes, and then open for questions? Could you put +1s or emojis in the chat so we know that you're okay with it? Okay, I see a lot of thumbs up. I'm just going to take that as a yes overall. Please go ahead, Jenna.
Okay. So we've spoken about authority and proof, and then the next one is around risk. So who carries the exposure of these decisions? If things are not going well, if the authority has been taken out of the room, what ends up happening is that that risk falls on the lone clinician, or inevitably it's actually on the patients. And the patients end up not having access to care and having to deal with a lot of that. And so the fourth lever is around support. And what are the structural, the relational, the financial, the psychosocial supports needed for those decisions to be made. So if we look at Arav's story, is that what we can see so easily is that the proof threshold begins to escalate. So even from the beginning, the entire assessment process that the psychologist actually went through is already over the top. You know, it's like you don't need a personality to test. You don't need that stuff. It's, you know, can the person consent? Do they have the capacity to understand what their healthcare needs are. And then when it went through to the psychiatrist, now the psychiatrist is not trusting the authority of the psychologist and that therapeutic relationship. And so, the request for more sessions or for further assessment, that starts to happen. And I think it's not necessarily that the psychiatrist is bad or is, gatekeeping or, I think it's often is just like uncertain, not trained, and often thinking that this is actually the ethical practice. This is when you're being cautious, you're being responsible. But it ends up putting Arav through a whole hoop of things, and inevitably, he falls out of care. Yeah, so we can see how authority and proof, those two levers tend to go together quite often. So when the authority moves out of the room, the proof demands go up. And then we have risk and support that tends to go together. So if the risk isn't evenly distributed, and the risk increases, then that tends to have an impact on support. But what it also means is that if if there's a problem with one of those levers, the other levers can be moved around in order to rebalance it. So what kind of brings this model together is the idea of lever balancing, and that's kind of the goal of continuing care. Yeah, so I'll like end with this is that what is the actual task then for providers is to keep the authority close to the relationship, that it needs to be clear within scope, what is the decision, why are these decisions being made, keep the proof proportionate and steady. If for some reason more proof or more evidence is needed, you need to be very specific as to why and what would be needed for you to get that proof and have a timeline. Otherwise, it just carries on indefinitely and it's the reasons for it are unclear. Concrete support systems, a lot of it is around networking. Civil society is so central in our context. Also, just like it's like associations. I mean, I think like the alliance that you've built is a perfect example of, how providers can actually find support with one another. And then around risk is sharing that responsibility evenly, so that it doesn't just fall on one person.
That's, yeah. Yeah, thank you. That's very helpful. So I love the word stabilizing the work and stabilizing. It's such a new word to me in terms of how we look at care and how we look at reflection and how we look at the work itself. I think it's worthwhile to acknowledge that the risk right now in India is being felt as a felt experience both by healthcare providers as well as by trans folk.
Yeah.
Because of the recent amendment where self-determination has been taken away as the way to be, and there are some other sort of wordings which create ambiguity in how welfare and legal sort of recognition for trans identities can be. There is a spread of uncertainty. And because actually the act has come and has been passed, but the rules have not been notified. So just for the audience, post the act coming into play, usually there's a book of rules which gets notified and sent out about how to do it, how the act is going to be implemented. So for example, who's going to constitute the medical boards, what are they going to be about, etc., has not been done. Until the rules come out, this is just for the benefit of all of us, till the rules come out, you are bound legally by the NALSA judgment, which was 2014, and the Act, which was 2019. So right now, effect on practice in terms of real time is more notional than legal. So I think just for us as healthcare practitioners to prepare ourselves to say, does this kind of uncertainty impact our provision inside the room? I think it's debatable in my mind whether gender affirming care has been impacted inside the room. I think what we need to do is to reflect on, is it the uncertainty and the anxiety of the healthcare provider? Is it my uncertainty when I'm sitting there? Because I don't know what the potential scrutiny could be on me. What could be the fallout of practicing in a certain way? So I think one of the things that is extremely important is for everyone to pitch in, and your voice really matters. If you could, please look at the survey that's been dropped in the chat. I'm also going to put out the QR code. I'm going to request my colleague to put that in. We're trying to collect data authentically across India from healthcare providers and care workers to say, has there been an impact? And if so, what? What is the kind of impact that you may have had? What is the effect of this legislation on healthcare delivery in India? The data of this survey we are hoping to use very responsibly, confidentially, for public dissemination, but with an intent to influence the policy on gender care provision and make sure that gender affirming care from the healthcare providers also point of view is something that we can continue to provide ethically. I would request each one of you, it takes approximately 5 to 6 minutes. Please download it. And like Dr. Sharma has written in the chat right now, there is no data to say whether or not healthcare providers have had any kind of change in the way that they're delivering care. But we need that data to be able to actually do anything beyond just talking about it. So that's my request to everyone. We did want to talk a little bit more in detail about the amendment and the possible effect and impact and what could be done. I think I'm going to do a very quick 2-minute on that. I'm going to invite KP in and Jenna for one minute to say, can we clarify for the sake of the audience here about what may change and what does not need to change in terms of delivering gender affirmative care right now post the amendment? KP, could you go first, please?
Yeah, so just to add to what you've already said, Kavita, about the act not being notified, rules not yet being out, there are a batch of 8 to 9 petitions that were heard in the Supreme Court on the 4th of May, and they have been referred to a 3-judge bench, and state and the central government have been asked to respond, etc. So this is not like, done and dusted. This is being contested, and that's something we must remember and keep in mind. But more than that, I just want to point to 2 things. That one is NALSA holds, which talks about self-determination of gender. The other is the Trans Act of 2019, the Transgender Persons Protection of Rights Act, has a section called Section 15, which looks at healthcare, and that has not been struck down. So amendments have happened to certain things, but the Section 15 is something that we should hold on to, which talks about a healthcare manual for the country along the lines of WPATH. So that's something we must hold on to as mental health professionals. We must, as mental health professionals, we are governed by our education, training, etc. We follow ICD 11 or we find following DSM 5. We could look at those because those are guiding principles in that sense in the clinic. The other very important act for us is the Mental Health Care Act, which has 2 things. Mental Health Care Act in India in 2017 says non-discrimination on the grounds of gender identity and sexual orientation in addition to everything else. And the Mental Health Care Act also talks about mental health care in India should align with international standards of care on various mental health issues. So that means we have, as mental health professionals, a range of things that we can dip into to be able to protect our practice of providing care to our trans clients. So while the amendments is a bit of a, it's the googly that has been thrown, I personally don't think that the primary target is, gender affirmative care and the care practice as a whole. We may end up being a casualty, and the way to respond to that is actually so at this point of time, we must educate ourselves on the medical legal aspects, but also on trans-affirmative care. So some of the stuff that Jenna has put together, some of these are, things that will really help us to be able to argue out how we are providing medical, legally, ethically, right kinds of treatment. So this is a time actually to educate ourselves on trans affirmation, on the legal aspects, and also to advocate, because I think we will also be called upon at different points. There are already committees and committees, right? So you may have heard about, I don't know, people here may have heard about the Asha Menon committee, which is of a retired justice from Delhi, who was asked to, develop some kind of a document on how to implement the Trans Act, particularly in the context of a trans woman who faced discrimination at workplace. So Asha Menon committee is working very hard. They're doing consultations. So there's a lot going on right now. So we all need to educate ourselves, get together, speak in as many places as we can. And we will probably be also, if these boards get notified, it is going to be mental health professionals who are going to be asked to come in and say, to be able to talk about, who's trans, etc. So we must ensure that we educate ourselves, but also know about bad practices. So, for example, I think in the eyes of many people in law, policy, bureaucracy, there is a conflation between intersex and trans. And so they actually think that we must do physical screening, genital screenings, etc., for trans people, which is terrible, indignifying practice that we will be able to oppose by just educating ourselves on what are the right ways of doing, assessments for gender incongruence and so on. Yeah, that's it.
Thank you. Thank you, KP. That was said at top speed. I wish we had more time. And as somebody in the chat says, could we put all of this together, what KP has said? Yes, we will. We will make these points and put them into the resource link. Please don't worry. You'll get it. If you download the resource link, it's a living document. We will keep adding resources to it. Please feel free to keep looking at it over time. Jenna, any closing remarks before we start taking some of the questions?
Yeah, I think just one thing is, I think the ambiguity in this law and things being quite unclear is that obviously destabilizes authority. And the lever model also happens across like 3 different layers of care, from like the micro, which is the consultation, to the service, to the macro. And these changes that's happening is sort of happening on a macro level, which then is filtering down and impacting care. And I think one of the ways that, at least that what we've tried to do in the South African context to reseat that authority, is that organizations that do already have legitimacy and authority have released position statements that are very clear about their support for gender affirming care and support for self-determination specifically. And, like those were endorsed by over 100 people internationally, as well as over 30 organizations. So I think it's like thinking about it in ways like that, of how, how gender affirming care can be supported on a macro level too, by looking at institutional networks and supports.
Thank you. That's very helpful. So again, just as information, the Indian Clinical Psychologists Association has put out a statement in response to the amendment. The Psychiatry Society hasn't, IPS, as far as I'm aware, but we're going to try. The Endocrine Society has, the plastic surgeons have. So I think, again, maybe for the sake of the resource document, we'll put all these statements into the resource document just in case people who are practitioners need to refer to it or need to show it to their institutions and sort of embed it back into the system that they're in. I think we should try and persuade as many such bodies, and take your cue on that, Jenna. On that note, I'm going to stop with our talking and maybe start with some of the questions. I'm going to start with the question which came towards the end, which is, would there always be gender incongruence present in people who identify as trans? In a roundabout way, what I'm trying to understand is that will my diagnosis of gender incongruence help or hamper their transition journey? That is an uncomfortable thought for me. Yeah. Who would like to? KP, could I ask you to break this question down into something, yeah, which is helpful. Yeah.
So just to, I think as of again, I mean, there's just ambiguity about many things. But right now, for example, in India, um, the only way in which you can get to any kind of medical or surgical transition, social transition, that is basically where you may say that this is my name, this is the kind of clothes I want to wear, this is how I want to be addressed, etc., is different. But if you need medical transition, surgical transition, you have to go to a mental health professional, and the mental health professional has to use one of the diagnostic label, that is gender dysphoria or gender incongruence, and say that you have one of these. They will, of course, look at, I mean, gender incongruence is defined as XYZ in the ICD-11. So they will say that you've been having this. So that will have to be done if you have to access any further interventions. That's not what is required as per WPATH, I think, as Jenna had mentioned earlier. So in that sense, gender dysphoria is not essential, or definitely a mental health professional certificate may not be essential. But in the Indian context right now, because we had a committee, I mean, I think that committee is also had put out something, those they have been asked to reconsider their recommendations. All that is still quite ambiguous, but the way practice works is a mental health assessment is essential. And the mental health professional who assesses currently mostly is a psychiatrist, but people with MPhil clinical psychology who are RCI certified can also provide this letter of support. To my mind, one could argue that anybody who has the clinical skills in terms of, who has clinical training should be able to provide these letters of support. Yeah.
So I'm going to add to that to say that if you look at it from the truth point of view, from the reality point of view, not everybody who identifies as a trans person has gender dysphoria. They don't. Many people do not. Oftentimes, the dysphoria and the incongruence comes due to the interfaces that they have to navigate because of the social structures and because of the resistance in these interfaces and the unawareness in these interfaces. Having said that, our implementation of care or healthcare guidelines have not taken this into cognizance. And because of that, this is the implementation is, as KP has said, that if you require anything which is medical, surgical, or state welfare based, where you need a trans identity, then you have to go through this process of a mental health professional. So this is what is called the gatekeeping model, and this is what currently is rampant, and this is what the amendment actually is in a sense nurturing. But just to underline, that is not the truth. This is a problem which is social and coming from the structures. In truth, gender and gender identity is self-owned. Everyone across the world, all professional bodies agree with that. Or Jenna, would you like to add?
It is often around I mean, it's essentially around accessing healthcare. That's sort of like it's like you need a diagnosis so that you can know what the treatment plan is. And so I think sometimes thinking about it in that way rather than as pathology, which I think is what the ICD-11 has actually done really well, is that they've just stripped it down, that it's about a code to access healthcare.
Hmm. 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 Okay, I'm going to another question, which is by a doctor. I'm a psychiatrist. As a doctor, would asking clients their expectations with hormone therapy, discussion about expected side effects of medications, and any discussion around surgery, would that be considered anti-gender affirmative? My supposition is that the question that you're asking is about, so there is an implicit understanding here. If the person has come to you, then they have possibly come for some of these things. In case they have come to seek help for either surgery or their preferences for hormonal therapy, then I do not see this as being anti-gender affirmative at all. If they're seeking to transition or even to explore the possibility of transition, then that is the gender affirmative stance of the practitioner to be able to present the knowledge that you may have from your expertise in these things. Actually, yeah, so I don't know if I'm understanding the question correctly, but my answer is not be anti-gender affirmative at all. This actually would be gender affirmative if you are providing the right evidence that they have come to you for, and creating the space to explore these possibilities. It does not mean you're pushing them towards it or not. You are not giving an opinion to say you must do this. It is to support the person on their journey of exploration about what are the possible options they may wish to consider when or if they wish to transition. So does that sound all right, Doc? Yeah, could we have a thumbs up if at all? Okay. Are there other questions that we need to answer? Shruti?
That's earlier about intention, about in the context of language. So again, I mean, I would think that what is my intention is important. Sometimes mental health professionals do have, we do look for what made you this way, and abuse is a very common. I mean, I think that's where the question is coming from. Also, that I don't want to sound like I'm attributing the gender diverse expression or transness to abuse. So yeah, so I think checking that is important. Also, I mean, if that's if abuse, violence, discrimination, these are all things that clients bring in. I mean, we all sort of understand that if that's something that the clients need, that they would want to talk about it. That's not somewhere where I'd go on my own, because I have read that this is the prevalence of maybe discrimination or violence in people's lives. So that was just a quick response. So if the client brings it up, then that's something that, and I don't connect it causally with their transness.
Yeah.
Yeah.
And
I think,
yet, yeah. Sorry, Jenna, please go on.
sorry, I was just going to say that I think, yeah, I mean, I think it's just gender-based violence and sexual abuse is like, it's awful in South Africa's context. And so where it sometimes comes in our intake interviews is when we're looking at what the person's support system is. So say now they're coming in because they're wanting to start hormones. We look at what their expectations are, what the side effects are, and that is all part of the informed consent process. But we try to very discreetly, without re-traumatizing somebody, asking them about if, what the exposure to violence and interpersonal violence and that is like, because possibly what they're needing is additional psychosocial support. So I think it's like you can frame it in different ways where it's not framed in like what the cause is or if this is what made you trans, but actually as a broader package of care, what other support needs you need.
Yeah, yeah. And also just to remain aware that that there is a higher degree of possibility, and therefore your sensitivity as a healthcare provider has to be higher as well. But that is true for not just trans folk, but for other folk as well. We're going to have to close in a couple of minutes. I've got one question here for Jenna, who you mentioned that pressure on some levers could be counteracted with easing out on other levers. Could you please elaborate on how that could work in real life practice? Do you need another 2 hours for that? Uh, to actually do that, which brings me to the question of saying, does the audience want another session to address some of the things that we have been unable to address right now? Please do put it in the chat box if some of you are wanting. In the meanwhile, instead of taking this as a question, Jenna, could we go to the question which says, do we have degrees of gender incongruence and what are the implications if we do? So do we have degrees of gender incongruence and what are the implications if we do? Could we answer that one as the last question and close?
Oh, do you want me to?
Yes,
Okay.
please.
Yes. No, we don't really have degrees of gender incongruence. But I think people's like levels of distress around their gender and particularly social dysphoria, how they're being treated by other people and how other people are perceiving their gender, that relational stuff. That can vary from person to person, and it's often context support, dependent. So for trans people who do have supportive families and a supportive network, that distress might be less. When they're in affirming care and they have a lot of affirming experiences, that also helps, with the distress. So I think I don't think it's kind of like with a lot of other sort of disorders in the DSM where we talk about the degree of severity and, the GAF score. It's not quite like that.
Yeah. Anything you might want to add as a closing remark, KP? And then we will, yeah. Okay.
I think I'm good, yeah.
Yeah, so thank you very much from the entire IMHA team and to the entire IMHA team. But thank you to the audience for staying the entire 1.5 hours, for asking such questions. I hope we are going to be continuing to hold space for any kind of question and to be able to co-create some of these knowledge bits together. And special thanks to Jenna for being so willing to exchange and sort of give wholeheartedly all the knowledge and work that they have done. And thank you, KP, for being the simple yet bringing simplicity and clarity and really going to the core of the issue each time. Thank you very much to the entire audience for being interactive.